This is a big pleasure to be here and moderate this symposium. This is important for us. We will speak about some themes that perhaps you think is not important, but in the very end, there is a big importance in posterior capsulotomy, also SLT and dry eye. And they are linked. And we will see how they can be understood as an entity that we are looking for quality and for excellence. I would like to present, in behalf of Professor Beatrice Kocher, to Dr. Anas-Alexis BENYOUSSEF, who will talk about PROCAP capsulotomy. What added value? Thank you.
Dear colleagues, good morning. I've got the pleasure to talk with you about a new way to perform capsulotomy. That's name is PROCAP, and we will try to answer the question, what is the added value? Well, posterior capsular opacification is still a hot topic. Why? Because we've got an earlier onset, because of the material sometimes, because of the design, because of some patients, eye myopia, diabetes, inflammation, young patients, children, and failure to fully wash the bag. We've got kind of solutions like preventive square edge, capsular polishing, but still a level of 20 to 50% of YAG between 2 and 5 years. There's also an earlier revelation with some IOLs, including multifocal diffractive implants and EDOF, with a worsening of contrast as soon as fine fibrosis occurs. Well, that does not explain everything, and we consider that the best is to wait until 6 months to perform a YAG. What are the consequences? We know them as Eschning pearls, capsular folds, fibrosis, sommering rings, that will and we will have on this patient visual loss, halos, and contrast sensitivity. What are the main limitations? Of course, the learning curve with the more young ophthalmologist, with a curve on focus, on setting the energy, and we recommend some design, cruciform pattern, on dilated pupils with specific focusing glass, and using a post-op laser treatment to lower IOP and against inflammation. The risk should not be underestimated with pitting on IOLs, floaters, eating the vitreous, macular cystoid edema, and defocus with wide open apertures on YAG. Lumibird performed a survey in 2022 with 113 responses, and here are the results. 50% of the ophthalmologists create an opening of less or 4 millimeters, and 79% use a laser posterior offset. The new with PROCAP is an additional posterior detent at 2 millimeters. The Tango Reflex Neo Laser YAG is a new generation because of its extended posterior YAG shift until 2 millimeters, because of his head-up display, his dual-function joystick to change the power, and a screen that can send DICOM informations to your devices. Please use a glass. The glass is required to make the better results. We also have reflex technology on this laser. It means real coaxial light. We know traditional oblique illumination, but with a real coaxial light, you will have you can align the focus, the light target, and the laser beam in one optical plane. The aim is to have a full reflex of the retina, and we can do that with the reflecting mirror. You can do that 4 times per second. And we have on this laser a double green laser light that is very easy to perceive and easy to locate. What is the aim of the extended posterior shift of the YAG laser? Originally, it was designed for floaters treatment. It's a short, low-energy YAG laser pulse that is delivered behind the posterior capsule with a ionization of intraocular matter that occurs with the formation of plasma. It causes a rapid growth and disintegration of cavitation bubbles accompanying the shock wave and moving towards the posterior capsule. Thanks to the safety margin, as in the video, we've got, with the posterior shift, it's possible to send the initial opening impulse directly to the center with implant safety and reducing floating bodies. The concept of the YAG is to have a massive power peak in a short time. It's enough energy to strip electrons from their atoms, and this causes ionization. That's why we can see a spark when a YAG laser is fired. The result is immediate vaporization of the material, which causes the formation of cavitation bubble. Laser is not the main mechanism for tissue rupture with conventional photodisruption. Stage 1 is a massive power peak, nanodomain, and stage 2 is a cavitation bubble with growth and decay, it's the microdomain. It generates a mechanical wave towards the post-capsule that is sufficient to rupture the tissue. The light energy is transformed into mechanical energy that is the main mechanism used today with conventional photodisruption. But what is the natural life of the cavitation bubble? We said that with the conventional YAG shifts, less than 500 microns, it does not complete its natural life cycle. The mechanical wave hits the posterior capsule and the bubble collapses. But when you use a posterior shift that is higher, up to 2 millimeters, you can have a very different behavior with a bubble that will complete its growth and decay. If we consider IOL as a solid border in front of the cavitation bubble, this limit influences its dynamics and causes it to collapse asymmetrically. So from the cavitation bubble to the jet effect, in fact, we've got the leaving of a sufficient distance between the laser shot and the IOL, and the final stage of collapsing the bubble propels a high-speed jet of liquid directly towards the solid border. This jet effect has destructive properties, but it won't cause any damage to the IOL. Here we can see a video of a laser YAG that is performed, starting with the center with an offset of 2 millimeters. And about the life cycle of the cavitation bubble, we've got, with a sufficient posterior offset, the collapse of the cavitation bubble that produces a powerful hydraulic jet effect, cleaning the tissue of the capsular opacification, but without debris. Here we've got another video. The only difference between this video and the last generation is the color of the laser that is red here, but we know it green on the new laser. And Dr. Paul Singh started with the center and go to the corner, with, which allows to roll the capsule on these edges without floaters and without the risk of damaging the IOL. What is the premium management of PCO? Since there is still no way to avoid it, even if we've got prevention strategies like anterior and posterior polishing, anti-inflammatory, and designs, there is still no success, even with long-standing search, to avoid PCO. We are in a quest for effective and safe treatment, preserving from floating bodies, maintaining the IOL position, clearing the visual area, limiting energy dispersion, and protecting against alteration of the IOL. The ProCap is a standardized technique that reduces the floaters because there is a wrapping around the edge of the capsule without fragments, with no damage to the IOL. And in our experience in Brest, in the city of France, on 3 months with juniors and seniors, we use the ProCap with a focus of, with a good focus, but with 200 millimeters backwards. And we increase the energy, sometimes over 2 millimeters until 5 millimeters, 5 millijoules. Starting with the center, wrapping around the edge, and yes, we've got fewer floaters. So we're talking about the cataract premium circuit. We know that the lens dysfunction will need a surgery. Firstly, we will assess what is the problem of the cataract. We then use biometrics with latest generation Kekulen formulae. IOL selection based on the age, on the eye, on the needs, and on the expectations. The latest mini-incision surgery techniques. And now we can complete this cataract premium circuit with a ProCap. Thank you for your attention.
Thank you. Is any question? We have 3 microphones. We can also make by text our questions. Is there any question for the audience? I have one for you. This is not new. We all perform capsulotomies. For your side, what is the clinical impact in this technique, in the summit? What do you think, why which you should change and adopt this technology to make the focus a little bit posterior? Is it because the floaters? Is it because the pitting of the lens? What is your clinical approach for?
For me, 2 things. The first one is I'm in a university department and we've got juniors and we've got a matter of avoiding IOL pitting, but the main reason, even for seniors, is to avoid floaters. We don't have floaters. That's some kind of problem that we can have with other way to use the laser. And for me, it's the main advantage of the laser.
In your experience with residents or fellows, how was the rate of pitting with this device? Have you any idea about that? Or the floater or big floaters? Or no idea at all?
Well, IOL pitting is some kind of taboo. You don't want to say you made a IOL pitting, but I remember when I was resident, I've got one of my friends that performed his first CIAG laser. It was explained to him how to do it, and he made bubbles just behind the IOL and asked, "Is it normal?" Yes, no problem, you can have bubbles.
Yeah, it is reported that pitting of the lens is 5 to 30%.
And then he continues and said, "That's weird. Those bubbles don't move."
No.
Why? Well, you performed a very beautiful line of IOL pitting. Yep. And that's some kind of things that we see, I would say, at least at 50% with the most younger surgeons and ophthalmologists. And that's why they don't want to use the cruciform technique, even the ProCap technique, and they prefer to make something circular, but with more floaters. Really more floaters.
Okay. Any question in the audience concerning this?
I've got a comment, which is that I think if we can get capsulotomy that much safer, then we can universally treat from the center. And that's just, that would be always my treatment of choice for, central treatment to avoid free-floating capsular remnants. I've had patients within our health service at Moorfields being done by residents left with needing vitrectomies for capsular remnants because of their severe floaters, particularly young patients. And that's a disaster. A very safe, simple procedure to then have to go on to a vitrectomy to remove a floater is a disaster. And why did they have that? That's because they had a circular capsulotomy and then the piece fell back and caused problems. There are many hospitals in the NHS in the UK where the protocol is only for circular capsulotomies because they are scared of central lens pitting from inexperienced users. If you can make the margin of safety so much better as you've so nicely described, then I think that's a real boon. So thank you.
We are not talking about this, but the Tango Neo reflex also, because the reflex technology and the coaxial vein could be used also for electrolysis. But this is another tema. The next tema is we invite Professor Gus GAZZARD from London, UK, and he will talk to us about overcoming barriers to SLT as first-line therapy for glaucoma and ocular hypertension, open-angle glaucoma.
Thank you very much. I'm going to talk about some of the evidence for SLT, why we're doing SLT, what it is, and then talk about why I don't think we're doing as much of it as we could be or perhaps should be. I've got some research funding, mainly from the UK NHS. I've got some financial disclosures because I've spoken about SLT and various other things in a lot of circumstances. What would be the perfect pressure-lowering treatment? It would obviously be safe, effective, repeatable if necessary, but with a long-lasting effect, so hopefully you don't have to repeat it that often, that works for everyone, regardless of race, color, creed, origin, age, gender, independent of what the patients need to do. So patients who have SLT don't need to remember to take their medications. They have it done, they just need to remember to turn up to checkups twice a year instead of putting in drops twice a day. And hopefully it won't impair subsequent treatments. And I think if something in our treatment can work through traditional physiological standard pathways, then that's probably better for the eye in general, as a general principle. And SLT fulfills a lot of those requirements, I think, very nicely. Unlike ALT, it's much less damaging. We don't get punched out little craters in the trabecular meshwork. You just get very gentle stimulation of macrophages to clear blockage and possibly stimulation of stem cells in that stem cell niche that occurs at Schwalbe's line to repopulate trabecular meshwork. And in some patients, give you pressure lowering for 5, 6, maybe even 10 years. So why aren't we doing more of it? Well, that was the question I asked myself, and after a corridor conversation a decade ago, led to 10 years of hard work and a trial. But I was by no means the first to do that. It had been suggested long before. Alvarado had looked in great detail to the mechanism of why it might work. There is a part of me that thinks it doesn't really matter why it works if it does work. Which is why I put my energy and efforts into proving whether or not we should be doing it rather than trying to explain exactly how it was working. And that generated a 3-year paper where we showed that 3/4 of patients were drop and surgery free, as you're probably aware by now. And 3/4 of those had only needed 1 laser. And it was incredibly safe. So 1 patient had required treatment for a pressure spike in those 3 years. And by the time of 6 years, we only had 10 eyes out of 979 lasers. These are mild to moderate eyes. These are early in the disease course. These aren't patients who are heading inevitably towards surgery. So these are low-risk patients. But it showed us how safe laser could be. We then extended that to a 6-year trial follow-up. Slight differences for that second 3 years because we allowed patients to cross over, which has helped us to demonstrate that even after 3 years of eye drops, laser can still work and get you off your eye drops. You're not condemned or committed to drops if you've already started them. So if your patients are coming to you having been started on medication, whether that's prostaglandin or beta blocker, doesn't matter. Laser can still work and can get them off their medication. There's now good, robust evidence for that, you'll be pleased to hear. And the 6-year outcomes for the 6-year trial follow-up showed that over the further 3 years, a small number of eyes had continued to, the pressure had crept up slightly, which you'd expect for glaucoma patients over a further 6 years of life, but we still had drop-free control in 70% of patients. So these are patients taken at the time of diagnosis The first step in their journey is laser, and 6 years later, 7 out of 10 are still controlled without disease progression, with good pressures, without needing medications, without needing to expose themselves to drugs, drops, preservatives, benzalkonium chloride, and all the problems of ocular surface disease and dry eye that can cause. We also had a number in the other arm that started off with medications who crossed over to having laser, who, as I said just now, also responded well. And there were a number of other things that we were able to do. I'm going to just comment upon this briefly, just to remind us that now we have good, robust, published evidence, published in ophthalmology, that doing the laser first, rather than medication first, was actually able to preserve visual field better than the drops group. Even though they had the same average pressures at the end of 6 years, laser was somehow working better. My personal view is that people don't like taking drops and that the laser's working whether they like it or not. So whether they're asleep, whether they forget about it, whether they're forgetful, the laser's still controlling pressure, whereas the drop treatment for their medicated glaucoma relies upon them to remember to get their medication, to go to their physician, to get a script, to go to the pharmacist, to collect that script, and then day in, day out, to actually use the damn bottle. Now, a lot of patients don't do that, and we know that well. There was more than that. It was more than just field preservation and drop-free pressure control. We actually had better disease control. And even after crossover at the 3-year time point, the SLT arm was still doing slightly better. The disease progression defined here as deterioration in visual fields or deterioration in nerve status based on neuroretinal rim width. We also had fewer trabeculectomy rates, and that difference continued to diverge even after 3 years. And there happened to be slightly fewer cataract surgeries in the laser group as well, although that was significant, but probably not clinically really important. We had some additional analyses that we did that showed that there was a good 30% reduction from laser if you use it as your first treatment. A lot of outcome studies for MIGS, for laser, for other things, look at a 20% reduction as their outcome measure. We found that there was just shy of 30%, I think it's 29, 0.7, I think it was, the same significant, non-significant difference from the prostaglandin response for these eyes. So we're getting a big pressure response when we're doing laser as the first treatment. And we could also repeat it. And not only was it possible to repeat it effectively, but that repeated treatment continued to work for an even longer period than the first 18 months of those initial failures. As I said, we weren't the first to suggest laser trabeculoplasty of some kind as their initial treatment. Hat off to Anja Tolonen, who back in the early 80s did a retrospective study of ALT, as was the only one available at that time, and showed that laser trabeculoplasty as a primary treatment could work very well at controlling all sorts of open-angle glaucoma. So why on earth, if we have had an inkling and known this for so long, are we not doing more of it? It took 10 years and a £2.5 million trial to change terminology and guidelines from the EGS to persuade the American Academy of Ophthalmology that primary treatment should be a suggested option rather than just a secondary or third line treatment. And now we've got to the stage where the National Institute of Clinical and Care Excellence in the UK, NICE, which is the thing that tells our patients what they have a right to demand of the state-funded health service, NICE now mandates that SLT should be offered as first-line treatment to every patient. So it was a huge amount of work to shift the evidence base. Now we've shifted the evidence base, how are we going to persuade people that this is the right thing to do and shift their practice? And if we're not doing so, why is that? If you talk to a lot of people, they say, well, I know SLT works, and Gus is going to talk about the laser trial again, but, it's much quicker for me to write a script. It's much easier for me to do that than to actually do a laser. I haven't got a laser, it's down the other end of the corridor, whatever it is. I think there are lots of problems with inertia, but I think if we're honest with ourselves and do what I think of as the grandmother rule, which is what would I want for my mother or my grandmother if they had high pressure, Do I want to condemn them for the rest of their life to the side effects of prostaglandins and beta blockers and topical treatments and forgetfulness, or could we be doing laser for them? Then I think we would say, well, no, of course I would want laser for my family, so why aren't we doing it for more of them? So what is the problem? I think partly it's an underestimation of how straightforward SLT is. Gonioscopy is not difficult or scary. Anyone who can handle a slit lamp can do a gonioscopy. Anyone who can do gonioscopy can do laser. I think we underestimate how safe laser is, not just the success rate, the magnitude of the pressure reduction and the duration of action, but also the safety. So I think that the light trial, one thing that it showed that is if you start with laser, when the trabecular meshwork is still relatively young, relatively amenable to modification, or rejuvenation, or rescue, then I think we've got much longer treatment effects and much greater treatment effects than if you do laser at patients who've had drugs, drops, benzocaine chloride for a decade. And I think a lot of the data that's out there that some people are taking notice of is not sufficiently emphasizing that they're treating the wrong patients. They're treating patients who've had drugs for 10 years that should be having surgery. We're treating patients at the start of their journey, very early on, within the first, at the very beginning of their journey, at the beginning of the trial, and then after 3 years at the extension. I think we also underestimate quite how bad eye drops are. I think that the magnitude of the marketing machines of big pharma have tried to persuade us that drops are marvelous, but actually the patient burden from medication is huge. The cosmetic burden from prostaglandins, the periorbitopathy, orbital fat atrophy, deep-set sunken eyes after 10 years of whichever prost you choose, they all do it. The ocular surface disease, the long-term toxicities from the medications themselves, as well as the preservatives. The range of systemic side effects that we often don't ask about. If we don't ask, we don't know, we don't hear. The cost to the service of lifelong medications or the individual. And I'm a bit of a cynic, so we should probably also think about pharma marketing. But I think we underestimate all of these things, and so we get the balance and we get the choice wrong. I think we also overestimate how good patients are at doing what we ask them to do. A lot of our patients take their medications the week before they come to see us because it's there in the diary, but for the rest of the 6 months we're not seeing them, they don't, or not often enough. And that explains why patient behavior independent treatments, whether that's SLT at the start of their journey or whether that's a phaco-MIGS procedure later on in their journey, that explains why those two sets of treatments which are patient behavior independent seem to preserve visual fields better. There's good evidence now that phaco-MIGS from the Horizon trial preserved visual field better than phaco alone. And what is the reason for that when the pressures were very similar because the phaco group was more medicated? It's because the medicated group had to remember to take their drugs. So patient behavior independent treatments that don't rely on your elderly patient remembering their medication, I think is a real boon. And I think we underestimate also, the safety and ease of SLT generally as a profession. So the traditional experience of a patient is just a lot of drops and then surgery and then they start again. What's wrong with medical treatment? Well, I've touched on the side effects. I've mentioned ocular surface disease. I've mentioned problems with compliance. I think we underestimate all of those. If you read any of the data on patient compliance with medication, you will see that they simply don't do what we ask. There's lots of good, robust data that fewer than 30% of patients are able to comply with the treatment regimes of even simple drop regimes. And even if you do that in the UK, where they don't have to pay for their medication's free, they've already paid for it, they're still not using their medications in the way they should be. So anything that can take that away from them, I think, is better. And I think we as physicians, as clinicians, are making a mistake about underestimating how much harm we're doing, what we're doing to the dry eye and the tear film stability, how good our patients are at doing it. And what we should be doing is finishing, putting an end to that by starting them on their journey with their SLT. So Adverse effects of medications go on beyond those of our patients. When we finally come to surgery, a lot of patients have much higher rates of surgical failure if they've had drugs for 5, 10 years. That's very well established for many years, both with old medications and with more modern preparations and more modern medications. I think we're just doing them a disservice. And to finish on a positive, happy note, I think what we should be doing for our patients is offering them something that may not work for everyone. It may not be enough for everyone, but try and get over that barrier that we have of starting off on this journey of primary treatment with an SLT, because that's going to work better for our patients and give them a better quality of life and visual outcome at the end of it. Thank you very much.
Thank you so much. It's very important because this last part of your presentation is linked for the next presentation, dry eye. And
that wasn't an accident.
Yes. There is some questions I will show to the audience. The first question is, you recommended SLT as first line regardless the stage of the glaucoma, even in advanced cupping? Or what about secondary open angle glaucoma, pseudoexfoliation, for instance?
I do not distinguish between, when I'm offering SLT, I offer it to everyone, because I think what we know now is that it's very safe. And my hesitancy 10 years ago about giving SLT to advanced disease, my worry was that there might be a pressure spike which could be dangerous. I think we now know that as primary treatment, those pressure spikes are rare. Those pressure spikes are things that we can treat very readily. We pre-treat with an alpha agonist for all patients, and that pretty much obliterates the occurrence of pressure spikes. SLT, the difference is that if someone's got advanced cupping, SLT on its own may not be enough. So I do not promise a patient with advanced disease drop freedom and drop independence. I don't say you're never going to need medication. What I say is let's start with laser to see how well it works, but you're probably going to need something to top that up because your target is lower than the next guy. So I do use SLT in advanced disease. I do try SLT in secondary glaucomas of a wide range of sorts if they have an open angle, but I think there's a much lower rate of success in a number of those secondary glaucomas. But my view is it's probably worth a try, but let's manage expectations. I don't quote the results of the LIGHT trial to patients with secondary glaucoma because they weren't in the trial. I say, look, I think it's worth a chance. It may well be successful, but be prepared that it might not work for you.
You show us all the evidence. We see the evidence. We see the results, but we don't change our treatment. There's a mental barrier inside everyone. We are lazy. We don't want to change our habits.
Yeah, I try not to say lazy. I say inertia. I think we all have inertia. You know, there are many habits that we should change that we don't. It takes a lot of energy to try and, whether it's exercising more, even if you know that it's good for you, or or prescribing or doing more laser. Particularly if there's a capital outlay involved because your unit doesn't have that laser. But I think it's something that ultimately we owe to our patients, and I think it's something that now, with the level of evidence we now have, that we need to get over that inertia and just accept that it's not scary, it's not dangerous, it is effective. It's not a perfect cure for everyone, for all people, and we mustn't pretend that it is. But we also have to look at some of the so-called real-world evidence with a degree of skepticism and remember that we're starting the journey here, but we're probably going to be able to keep a lot of patients without medication for the rest of their lives if we start and just do occasional lasers. And that's a great goal to aim for.
I mentioned laser because, not for the glaucoma specialist, but general doctor, they don't want to perform, again, gonioscopy as a routinary process, and perhaps it could be a barrier. And also for the young people, it's also, they don't have enough skills to make the...
Yes, I mean, anyone who can work a slit lamp can do gonioscopy. Anyone who can do gonioscopy can do laser. And with good anesthesia, lots of coupling fluid and a nice large high magnification Goldman style lens such as a MagnaView, I think it's something that is not just within the potential skill set of everyone in the room. It's straightforward. It is not difficult. I really think there's a tendency to overestimate the difficulty of it. We're not asking people to make fine judgments about whether that iris process is PAS or whether that angle Schaefer width is 5 or 10 degrees. Because you know what? That doesn't really matter. If it's open, it's open. And if you can find where the iris hits the sclera, you found the angle. If you can find the angle, you can do SLT. So it ain't scary and it ain't difficult.
Thank you so much.
Dear colleagues, dear friends, it's a great pleasure to talk about new trends in dry eye that you see that have been greatest technological advances in recent years with a lot of new diagnostic and therapeutic tools. So it's a huge challenge for me to summarize in 15 minutes what I've been working full-time for 10 years, but I will try. I chose these 3 topics to give you an idea of the latest developments in dry eye, a new dry eye score, a new therapeutic tool, and IPL protocols. Let's start. In the 90s, the great fear of the refractive surgeon was failing to detect fresh keratoconus before LASIK. Numerous teams worked on developing a score or index to prevent this problem, and now the problem is largely solved. To date, we have a reliable, effective, and reproducible score for dry eye. Nowadays, we only have subjective scores for dry eye like OSDI, SPEED, DEC5, SANDI, and no reproducible automatic index, as we have in keratoconus. I'm going to show you the score we have developed to rate dry eye, and I hope I can prove it's useful to you. In this slide, you can see our group of experts and the goals we have set in the attempt to establish a useful and reliable dry eye score, which should be done in few minutes. To establish our score, we screened all the current diagnostic tools, including all the mammograph, all the OCT available in France. This prospective study, based on the review of 10,000 dry eye consultations, allow us to segregate 4 perfectly objective and reproducible factors. Once we had established these 4 criteria, we tested them on 1,000 patients from 6 expert centers in France. 2/3 of the patients were women, with right eye, left eye symmetry, and the predominance of obstruction as the main factor in the ETAO abnormality. We performed classical statistical analysis to assess the reproducibility of the parameters tested. So, today, I can show you for the first time this new score named ETAO, each whose parameters can be quantified using the procedure shown in the slide. For corneal epithelium, telangiectations, meibomian gland atrophy, and meibomian gland obstruction. This software is powered with a machine learning algorithm and will soon provide us very detailed statistics. This ETAO score is useful for several subspecialty consultations in ophthalmology. ETAO allows monitoring diagnosis and monitoring patients with dry eye and to propose the optimal treatment. ETAO helps prevent postoperative dry eye in refractive surgery, particularly in LASIK. ETAO helps prevent corneal toxicity from hypotensive eye drops and to choose the best lens for cataract surgery among some examples of its application. Here you can see some reports generated automatically by the software, which is designed to run on most diagnostic devices in order to make it a gold standard for dry eye. I selected 6 clinical cases to show you how ETAO works. First one, 27-year-old male consulted for LASIK. ETAO was at 7.50 because of huge telangiectasias and significant obstruction of meibomian gland as you can see on the slide. Obviously, he was recused for LASIK as recommended by the ITAO. Second case, a 49-year woman consulted for presby LASIK. ITAO was at 6.94 because severe bilateral obstruction of the meibomian glands and evident ocular rosacea. She was also recused for LASIK in our center as long as surface damage remains unsolved. But she underwent LASIK in another clinic. Since this LASIK, she had all the complications expected on this very pre-op damaged ocular surface, which resulted in deep depression and suicidal thoughts as the pain she felt was unbearable. I deplore having so many similar cases in my dry eye consultation. The tragic thing is that all these complications are avoidable with a score like ITAO, which will formally advise you against proposing LASIK in such cases. Clearly, the ophthalmological community needs to find a solution to the problem of dry eye after LASIK, and once again, the example of pre-op screening for keratoconus before LASIK motivates us to do the same with the prevention of post-LASIK dry eye. And we hope that ITAO can be one of the solutions. Third case, a 67-year-old man consulted for irritated and dry eye since taking travoprost and bronzolamide for 2 years. ITAO was at 7.50 because of severe obstruction, damaged cornea, and ocular rosacea. You had 2 problems to solve for this patient, IOP and dry eye, so it was perfect indication for SLT as Gus recommended, plus IPL and stop eye drops. In our practice, corneal epithelial OCT is systematically performed as a part of glaucoma follow-up, which help us anticipate potential ocular surface disorders. Fourth case, a woman, 81 years old. She underwent cataract surgery with multifocal IOL on a very damaged surface. She was very uncomfortable since her phaco, despite the perfect optical results. ITAO was at 7.8, and its use pre-op could have prevented this bad indication of multifocal IOL. A similar case to the previous one, with ITAO at 6.67, another bad indication of multifocal IOL with a very hungry patient with her surgeon because of the inappropriate indication for the multifocal IOL. Because of the very high costs of surgery for a multifocal, the post-op result has to be perfect in every aspect, and the sensation of dry eye ruins everything. A case like the previous one, with an ITAO at 6.19, between an head-off IOL and a very happy patient. In my opinion, in cases of damaged ocular surface with an ITAO at orange or red, head-off IOL should be preferred to multifocal IOLs. So, we made an excellent diagnosis thanks to the ITAO, and the patient says to you, okay, doctor, congrats for your nice diagnosis, but now, what's the solution to my problem? So, here are the solutions. As we've done for diagnostic devices, we have personally tested all the devices available for treating dry eye to try to find a decision tree to validate the benefit and efficiency of each treatment. And if someone tells you that this device solves all problems, you know we're dealing with a clown. As with most medical problems, it's important to make the correct diagnosis and adjust the treatment to each individual case. We tested all the IPLs, the LipiFlow, the LLLT, with all the LED colors, jet plasma, iLux, Tixel, Meibo-1, without forgetting the cheapest and perhaps most effective instrument, the meibomian forceps. And how to deal with the wide range of these different treatments. To simplify the problem, we have defined the major issues to manage: gland atrophy, inflammation, neuropathic pain, and gland obstruction. And so we have to deal with these 4 problems as best as we can. What's the solution to each problem according to ITAO? For inflammation, it's IPL. For pain, it's IPL and possibly QMR. For obstruction, it's IPL with MABO expression, LipiFlow, or ILEX. And for gland atrophy, we don't have yet any solutions. So, as you can see, IPL is clearly the most polyvalent treatment for dry eye. I'm often asked if I had to use only one technology, which would you keep? And today, I'm definitely say IPL. But not all the IPLs are equal, and I will explain why in a few minutes. As I said before, I personally tested all the IPL available in France for the treatment of dry eye, and in our center, we have chosen to work with these 3 devices because of their efficiency and reliability in laboratory tests, as you can see on your right. We have just seen that IPL is the most useful and polyvalent treatment for dry eye, and we have going to see which protocols used and in which indications. Here are the technical characteristics of System. With a highly protective filter for short wavelengths at 610 nanometers, suitable for all skin pigmentation, and an optimized pulse train which cannot be modified, which, in my opinion, is an advantage for avoiding setting errors. Here you can see the system working on patients. So, if you can answer to this question, you don't need to come with our courses because you know all the answers. But all the ophthalmologists want to be something easy. So in my opinion, an optimized pulse train makes your work much easier if you don't want to go into the technical details of how pulse trains work. On these 3 videos, you can see the classical dry eye IPL protocol on the left. In the middle, the protocol for dry eye in rosacea. And on your right, the protocol for dark skins. So with the system, you can proceed IPL even in very dark skin, as you can see. You have to modify the fluence and not be over 4 joules per centimeter square. So, without going into the technical details, it should be pointed out that the indications depend on the IPL device you are using. And the first generation devices without pulse train and with bulky and heavy light guides cannot be compared with second generation device with regulated pulse train and handy light guides. We don't have time to go into details on indication, but here you can see the current indications for IPL and dry eye. Most frequent indication is ocular rosacea, which may be or maybe not associated with facial rosacea. In the case of rosacea, IPL is used to solve the inflammation created by telangiectasias, as you can see on your left. The second main indication for IPL is obstructive MGD, in which the meibomian gland produces poor quality meibum. In this case, IPL combined with MABO expression helps to disobstruct the glands, as you can see in the MABO expressions before and after IPL. The third main indication for IPL is induced dry eye. It can be after LASIK or after hypotensive eye drops or after cataract surgery or after repeated intravitreal injections. This case is for Gus. In the case of dry eye induced by hypotensive eye drops, SLT is clearly recommended. In addition, I think that for all your patients on long-term treatment with hypotensive eye drops, you need to ask yourself whether if you cannot propose the successful combination SLT plus IPL. Thank you for your attention, and for those interested in IPL, I invite to come to Paris in October to the first IPL and Dry Eye Summit. Thank you.
Thank you, Pablo.